All right, let's go. Welcome to today's American Community Media Weekly National Briefing. I'm Sunita Sarabji, your moderator today and co-producer of our weekly Friday briefings with my colleague Pilar Marrero. This week, we turn our focus to the rise of some vaccine-preventable diseases. For example, 35 states to date have reported outbreaks of measles this year, with 1,079 cases overall. The number of whooping cough cases has doubled over the previous year. And the US used to be the world's largest contributor to the global vaccine program, Gavi, but cut its funding completely in January. Our briefing will examine vaccine preventable diseases rising in the developing world and the impact to the health of Americans. We will also examine the new protocols for development and distribution of the COVID-19 vaccine. Far fewer of us will be able to get a booster shot this fall. And we will also look at a possible resurgence of HIV/AIDS and the fate of the President's Emergency Plan for AIDS Relief, PEPFAR, established in 2003 by President George Bush. PEPFAR's reauthorization expired in March, and it has not yet been reauthorized. This is a lot to get to in 56 minutes, but we're going to do our best. So our distinguished speakers today are many familiar faces. Dr. Peter Chin Hong, Professor of Medicine and Director of the Immunocompromised Host Infectious Diseases Program at the University of California, San Francisco. Dr. Benjamin Newman, Professor of Biology at Texas A&M University. Dr. Gerard Ratavoisian, Associate Research Scientist at Yale University. Dr. Ratavoisian will join us at 11:40, and Dr. William Schaffner, Professor of Medicine in the Division of Infectious Diseases at Vanderbilt University School of Medicine. We ask reporters to enter their questions in the chat. We will go to Q&A immediately after each speaker presents, and we will send a we will send a video along with expanded bios later on this afternoon. So let's begin with Dr. William Schaffner, who will discuss the overall rise of vaccine preventable diseases in the US, along with a perspective on why measles cases have risen over the past 7 years. Dr. Schaffner, when we spoke, you said that this might not be the new phenomenon that we believe it to be.
Well, Sunita, thank you very much, and hello, everyone. You know, prevention is the most noble goal of medicine and public health, the elimination of disease. Vaccines and vaccination programs have reduced or eliminated many diseases in the United States population that used to be common: polio, chickenpox, diphtheria, whooping cough, neonatal tetanus, and of course, as Sunita has just mentioned, measles. As diseases have been reduced through vaccination, knowledge of them by new parents also decreased. And so, if the disease was not respected or even feared, the vaccines were not as valued. This led to more questions, hesitancy, skepticism, and even an anti-vaccine movement, resulting in the withholding of children or postponing children from vaccination, meaning there were more children, especially very young children, susceptible to these diseases. Measles, much in the news, illustrates at least some of these issues. The large outbreak that we know about in West Texas has occurred in one of the distinctive subpopulations that we have in the United States. We're a very large country, and we are rich in the diversity of people who live here. Rich because some are rural, some are urban. Some speak some languages, others have English as a second language. There are racial, social, ethnic, and economic distinctions. This is a distinctive population of conservative Mennonite people. These people do not have a distinctive religious objection to vaccination, but they lead a simple, natural life with a firm conviction in God's plan. They do have an aversion to things that are modern, and vaccines are modern, so that many children in this population are not vaccinated. They're susceptible. And when measles was introduced into this population, this most contagious of all viral infections spread widely, and there are now more than 1,000 cases that have been represented. Many children have had to be hospitalized for one of the prominent complications of measles, namely pneumonia. And we have recorded 3 deaths, 2 children, 1 an older person, who have succumbed to measles. Before we had vaccine, back in the 1960s, each year in the United States, 400 to 500 children died of measles and its complications. Measles is a fierce disease. We had reduced that number to 0 until this year. Now, this Mennonite population also lives in northern Mexico and Canada, and yes, measles has spread to them. And then very briefly, there are other outbreaks of measles that are occurring throughout the United States unrelated to this outbreak in West Texas. This is occurring in middle class, well-educated persons. Whether because of a lack of knowledge, no fear of the disease, concern about the vaccine, wishing to lead a more natural life, not wanting anyone to tell them what to do, a lack of trust in public health and conventional medicine, even a lack of trust in the pediatricians who care for them. This is a large problem. It won't be solved immediately, but that is the status of the circumstance in which we are working. We could talk for hours, but at this point, I think I will open the floor to your questions.
I have a couple of questions for you, and then we'll take questions from reporters. Reporters, please enter your questions in the chat. So, Dr. Schaffner, first question for you. As we cut funding for Medicaid and children's programs, do you expect to see fewer children getting vaccinated?
Well, this is a complicated circumstance, but the short answer, of course, is yes. If you cut funding for medical care and preventive health services programs, we will see fewer vaccinations. And the Medicaid program reaches out to people who are economically disadvantaged, where some of those children obviously do not have conventional medical insurance coverage for one reason or another. And that will leave a gap and increase disparities. One of the wonders of the US vaccination program until now has been that we have essentially eliminated disparities by race, urban, rural location, by ethnicity, and by language, because we have provided vaccines for all children. If this erodes, if this changes, we will go back to the bad old days.
Yeah, absolutely. Will states develop their own protocols for, will they develop their own mandates for vaccinations, especially for school-aged children?
Well, what I would anticipate is that the American Academy of Pediatrics and the American Academy of Family Physicians will continue to recommend comprehensive vaccination. And perhaps it is the case that some states, we have 50 states with a great diversity of resources and commitment, they might develop and enhance their own programs. I think this is all very uncertain. There's a lot of wait and see, Sunita.
Absolutely. So we won't name names here, but some have suggested that measles vaccines wane after a period of time. Would you agree with that?
Absolutely not.
Okay.
Measles vaccination, it's a normal 2-dose series, essentially protects you for life. And we've had a long, decades upon decades, 50, 60 years worth of experience with this now, and that's firmly established. Can there be occasional so-called breakthrough infections? Yes, but even those are milder than conventional measles that occurs in people who are susceptible. You know,
Yeah.
the vaccine we say is 97% effective, not 100%.
We'll take a question from Orhan Akurt. This might be more directed towards Dr. Chin Hong, but I'll let you answer the question as well, Dr. Schaffner. Orhan, would you like to ask your question live?
Yes, thank you. So after the COVID-19 vaccine, so people has more questions about the vaccines. So my question is, do you think people, they still trust the vaccines? So, and this affect any society so far as you see?
Oh, I think that the COVID vaccine, for many reasons that we could discuss, including the fact that it unfortunately has picked up a political veneer, uh, is still not trusted by many people, despite the fact that it has been as well studied as any vaccine that we have used and has been used by the millions and millions and millions of doses around the world. Remember, we're not the only country that endorses these vaccines. All of the other countries of the world have ministries of health that review the data regarding these vaccines and have endorsed them. Uh, One of the current controversies is who in the United States this fall should receive the vaccines, and we may get into some of those issues a little bit later.
Yeah. Before we move on to Dr. Newman, I would like to ask a question of all of the three speakers who are on here now. HHS Secretary Kennedy suggested earlier this week that his department would now create scientific journals of its own, dismissing long revered journalists or journals like Lancet, for example. What do you think of this move? Dr. Schaffner, let's begin with you.
Well, I'm concerned and distressed by it because the various journals that were mentioned were journals of great prestige and rigor and interrupting with the freedom of both the journals and the investigators to submit their work to these prestigious journals where they are reviewed critically by external experts before they are published undermines the means of scientific communication that we would have.
Thank you. Dr. Newman?
Yeah, hi. So to amplify Dr. Schaffner's remarks, consider money, nationality, and religion. All three of these play a very big role in whether or not a person is going to be vaccinated, and none of these matter at all to the infectious disease that you're vaccinating against. Because if it gets into a person, it spreads to the next nearest person, regardless of what they believe, where they worship, or how much money they have. Yeah. So, yeah, infectious disease has been a big problem for this country in the past. You could say it has held us back considerably and may again in the future. Consider how much of the modern world that we enjoy is only possible because of vaccination. all of the days that you are not in the hospital, all of the days that you can care for your children when they do succumb to illnesses. These are things that are gifts of the modern era and of vaccines very specifically. The current push to limit access to vaccines is essentially going against what will make America stronger. This is something that doesn't have any scientific support behind it and is puzzling on a scientific level. Scientists, which I consider myself one, are in the reality business. We are not in the business of hopes or dreams or anything else, which also play a big part in politics. And right now, there is no good reason for the pushback against vaccines, at least on a scientific level. All of this is coming from another sphere, and it's a sphere where data and graphs and scientific studies do not seem to penetrate particularly well. Is there anything in particular you'd like me to address, Sunita? Could you unmute?
Yeah, no, I initially had asked you to amplify Dr. Schaffner's, Secretary Kennedy has dismissed traditional scientific journals, saying that his department would create journals of its own. And I wanted your response to that question before you begin your formal remarks on our shutdown of USAID and its impact for American health.
Yeah, that is, I suppose I could imagine a world where it would be okay as long as the science is getting out there and the editorial standards are the same. But you don't make a change to make no change, would be my summary of the situation. And so I think it is very unlikely that that would happen. I think a change to these high-profile journals is probably aimed at degrading science, which is a shame because this is something where America has been really good. This is one of our big exports to the world in terms of ideas and products and services. And to undermine that undermines an important sector of our economy, and it's kind of the base on which all the rest of the economy rests right now. And frankly, it is very worrying to see that happening. The defunding of USAID is part of the same procedure. USAID used to run a variety of programs, and a lot of these were aimed at what they call soft power, which is essentially making people like you or giving them the opportunity to like you, yeah, where they might not otherwise. But a lot of those projects had to do with limiting infectious disease and detecting where it is. America has fought wars in the past in foreign countries so that they, or at least with the stated goal that they do not have to fight the wars here. It is the same with infectious disease. If you can stop the Ebola outbreak before a person gets on a plane, you have stopped the spread and you have limited the risk to countries around the world, including ours. We are heavily connected to the rest of the globe through trade and industry, and there is no unconnecting the United States. And because of this connection, connections come with risk involved with travel and shipment, and the risk is from infectious disease, among other things. That's probably enough, unless there's something else you need.
We have shut down, or we have stopped our funding for Gavi, the global vaccination program. And just for reporters' background, the U.S. was the largest contributor to Gavi. We funded 13% of its resources each year. Dr. Newman, what happens when we shutter such a major vaccine distribution program, global distribution program?
Yeah, obviously the results are bad. I think part of this ties into some of the changes that Mr. Kennedy has said that he would like to make. One of those is changing the way that new vaccines are approved and requiring trials with a placebo group, people that are deliberately not vaccinated, which is something that has been done in the past, and re-requiring it for every new update of a vaccine would add a few months and potentially mean that you don't get the vaccine until the virus season has passed, which would be very unfortunate. Yeah, programs like this have to be done in places where the virus is endemic, because otherwise you can't get an accurate test of whether the vaccine works. You can put it into as many healthy people as you want, but if you're in a place where there is no risk from a particular pathogen, you can't know the effectiveness, only the safety. And you really need to know both for a good vaccine. And so this is undermining that process for all of the future vaccines that may have come from it.
Yeah. In our earlier interview in January, I had asked you whether countries themselves are capable of doing the research to create their own programs to develop vaccines, etc. And you had said no. Could you talk about that a bit?
To some extent. With the measles vaccine, for example, there are many different versions of the vaccine. They're all very similar on a genetic level. They come from the same sort of stock from around the same time, but many different countries use their own, slightly different versions. So in theory, it's possible. I could make my own vaccines in the lab. I could try them out on myself, but that wouldn't be good science because figuring out whether it works for one person doesn't tell you if it's going to work for a second person or a country or the world. Yeah, you need much larger numbers, and everything gets easier with cooperation. The idea of isolationism is very counterproductive in science. It actually goes against the entire purpose of scientific journals. Because if I have to build the wheel myself before I can start to use it, there's no way that I can make much progress. Everybody's just a wheel builder and nobody gets to roll down the road.
Interesting. And Dr. Newman, what impact does cutting out Gavi have on American health? Do you expect to see, tropical diseases like Ebola, malaria showing up in the U.S.?
The world is a dangerous place. So measles only kills a few people per year in the United States, but around the world, it kills over 100,000 people every single year. It's a dangerous world because of these inequalities of money, nationality, religion, conscience that go into the decision of whether or not a vaccine will be available and will be taken up. In the short term, there will probably be only a small increase in these diseases. The risk is that one of these things might get started and might get going and might be impossible to stop. There was a time when HIV was in one person somewhere in Africa, and if we could have found it at that point and stopped it at that point, there would be no HIV epidemic in the world. Same thing for COVID, same thing for each of the influenzas. All of these things can be stopped so much better when they are still small. And we are taking our eyes off the prize by not paying attention to the outbreaks where they happen. Because by the time an outbreak of something new gets to the United States, it has passed through many people, and it may actually be too late to do anything about.
One final question for me, and then I'll take it to the chat. Are you, we've at the same time, we've also cut out funding for several NIH-funded research programs. Could you talk about the impact of that, and especially as it relates to vaccines?
There are many changes in NIH funding, and all of them are bad for science right now. Ordinarily, when someone comes in to shake up a system, they may seek to move it from a certain path to a different path, but would still provide a path. Right now, the path is being taken away by limiting what they call overheads, like the amount of money that's needed to that goes toward the university to build my lab and run it. It's the same sort of thing. If we're cooperating in that way, the university can do so much more than if I have to scrounge up the money to build my own high containment lab, import my own viruses, all the work myself. Wheel building is not the way forward.
Absolutely. Ritu Marwa has a question for Dr. Schaffner. Ritu, do you want to ask your question? Ritu, I'll ask it for you. Ritu asks, Dr. Schaffner, are we at a tipping point for measles? I'm not entirely sure what that means, but if you could answer it nonetheless.
Yeah, so Rito, I don't think we're at a tipping point if you mean that there's so much measles that it's going to spread widely in the United States. Please remember, still, fortunately, the vast majority of children are well vaccinated, and that protection lasts through life. So when we see these outbreaks that occur, they occur principally in the susceptible unvaccinated people. Yes, they leak out a little bit. There are a few vaccine failures. And as I said before, the vaccine is 97% effective, not 100%. So there may be some cases that do occur in people who are previously vaccinated, but they are few. So the basic protection of the population remains. Now, going forward, as more and more parents withhold their children from vaccination, obviously among young children, the number of susceptibles will increase and we will have more opportunities for outbreaks here and there as they encounter virus that comes into the United States from other countries. And just one other point, how does this virus get imported? Well, in the majority of times, it's our own unvaccinated children who go abroad as tourists or to visit families. They encounter the measles virus, the virus infects them, they get on the plane, come back, then they develop measles and they spread it to all their playmates and schoolmates. So the importation is actually done by our own susceptible children.
Interesting. Orhan Akurt has another question that I'll ask of both of you. Orhan, would you ask your question of Dr. Schaffner and Dr. Newman, please?
Yeah, that's a quick question. Vaccine is only choice to prevent from the resurgent disease.
Yeah, is vaccine the only choice that we have to prevent us from measles and other vaccine preventable diseases?
Well, from the point of measles, the answer is brief and yes, it's the only way. We have heard about other things. That's not correct. In order to prevent measles, you've got to be infected. We have other opportunities, social isolation, mask wearing and such, that work with other infections. Measles is so contagious. None of those have been ever applied in any effective way to prevent measles.
Dr. Newman, do you want to take on that question as well?
Absolutely. I had the same answer. There is no other practical way to stop the spread of something like measles. Total isolation of every individual, yeah, in theory would do it. But that is not a thing that can ever happen in this world because we all have families, for starters.
Thank you both. We are going to move on to Dr. Peter Chin Hong, who is going to discuss the new protocols for development and distribution of the COVID-19 vaccine, even as we see the emergence of the new NB181 subvariant. Welcome, Dr. Chin Hong.
Thanks for having me on.
Yeah.
So I can just give a few pointers, and then we can have people ask questions. But as many people know, there's been a radical change in many aspects of the COVID vaccines, and specifically mRNA vaccines. So some of the changes are that the COVID vaccine that's meant for the next version, which is late August, early September. First of all, we will have a new vaccine. Secondly, it will be distributed to people, but the change is that it's only now going to be for those 65 and older, or if you're under 65, if you have a comorbidity. The exact definition yet hasn't been released, but we assume it will be similar to how we thought about comorbidities before. So that's only between 6 months and older with comorbidities, everybody 65 and older. So that's not changing. But what's changing is no indication, at least by report, for the pediatric population who are healthy, including those under 2 years old, where we still see COVID severe disease, and very concerningly, no vaccine indication for COVID for pregnant people who are healthy and have no comorbidities. The reason why we're worried about those two populations in particular is that, first of all, most of the disease, I agree, happens in those who are older than 65, but specifically those who are older than 75 who haven't received a shot in the last year or so. But we also see serious disease in two other populations. One is specifically pregnant people, because they're relatively immune compromised. And the reason why they're immune compromised is because you kind of don't want to recognize, your immune system doesn't want to recognize the growing fetus too much. So that puts them at risk for lots of other infections in general, including serious COVID. The second group, of course, is those who are under 2 in particular, and specifically those under 6 months. And the reason why we see serious disease in that group is because their immune system is not mature enough. And particularly for those under 6 months, they rely on the antibodies going across the placenta and from the mom or the parent. And by eliminating the vaccine, even in healthy pregnant people, you wouldn't be able to protect that group easily. And then, of course, we knew that over the last year, there have been 150 pediatric deaths from COVID just last year, and we're already in year 5 of the pandemic, which is very similar to what we see for flu, which is a little bit above 200 deaths for last year. So if we're vaccinating everyone for flu, including younger people, and one would say that no death in a child is a good death, we should really think about that population. The other nuance, again, is that there's no occupation-based eligibility for vaccines by reports. So healthcare workers, et cetera, if you're healthy and under 65, would not have access to the vaccine. So there are things that are changing, but I guess there are things that are not changing. But the other thing that was odd about the way that this information has been unfolded is that it was in a 1-minute video on X instead of, and Dr. Schaffner will know this well, and Dr. Newman for sure, instead of the process of scientific advisors to the FDA, which met after the video. And then, of course, there'll be the scientific advisors to the CDC, which is called AICP. Typically, it goes in sequence, and then the CDC gives a recommendation, and then people look at the recommendations. But what we saw was a little bit out of order situation where with RFK Jr. and Macri and Dr. Bhattacharya going on a 1-minute video to say that these things will be changed. So at the end of the day, I think it leads to a lot of confusion in people. Right now, if you call Walgreens or CVS, they would still probably, they are giving you anybody appointments, because I tried by curiosity to make one myself. And I think Kaiser and so on are not changing their guidelines until it's official. But the fact that people are, the federal leaders are saying this is going to happen is making people sort of very confused. And I'm worried that it will lead to just even lower uptake in the fall because people will be worried that they will be charged with a bill, etc. So that's kind of like the general context. And of course, there are other developments as well, including sort of more attention on mRNA vaccines in particular, negative attention, even though, like was said earlier, there have been billions of people who have already used them. They have been, people have known about mRNA since the 60s, and then in human, as a vaccine since early 2000s. So it's been like around for decades already, and it's really, really promising for a variety of reasons, which we can talk about. But they include the fact that they're very fast. You can develop an mRNA vaccine in a matter of 3 or 4 months, versus a traditional egg-based vaccine, which may take 6 months or more. They are nimble, so you can have a mutation like we've seen in COVID or say in bird flu, and you can quickly change the vaccine while the season is happening. With mRNA versus flu, traditional vaccines will take a lot longer and they're much less flexible. And then number three, it adds to the storehouse of vaccines that we have available. So if you are kind of drawing attention to potential negative effects of mRNA vaccines, you're like taking away, a lot of just vaccines availability in case we have a new pandemic. So that's kind of what we're seeing with mRNA vaccines. Some of the specific news items are the fact that there's been more attention to heart inflammation in mRNA vaccines for COVID, and the change of the labeling to decrease the age group to 16 from 18. But the science hasn't changed. And in fact, one would say it's performative because that group isn't going to be eligible by and large for the vaccine anyway, if that's the way things are going to roll. And one would say that the risk of myocarditis or inflammation of the heart is even less now because very few people are getting one after the other, and most of the myocarditis was seen after the second shot within a 1 month period. So that's gone down. So that's drawing attention to mRNA vaccines. Another news item is that the combined mRNA and flu and COVID shot was pulled from FDA review. That even though there was really good sort of scientific evidence that it would give a very robust immune system, and a lot of people looking forward to it because it was kind of like one-stop shopping. You didn't have to get poked twice, but that's been delayed given some of the attention to mRNA vaccines. And of course, the biggest news with mRNA front is the pulling of the contract to Moderna to produce mRNA vaccine for H5N1 avian flu. And there were two installations to Moderna. One was like $150 million that was given earlier, and then there was one that was close to $600 million. That has been pulled essentially. So what it means is that there's less investment in using mRNA in terms of preparing for not just avian flu, but any future pandemic in the near future. So those are some of the aspects that are going on right now, both in terms of changing guidelines for the COVID vaccine in the fall, and attention to mRNA vaccines in particular.
Yeah, Dr. Chin Hong, there are a number of questions, but I would like to start. FDA Commissioner Marty Makary has said that there is no science to support people getting 80 shots in their lifetime. Would you challenge that of
Yes.
the COVID vaccine? Yes.
I mean, I think it injects doubt into people's mind. First of all, that much of what we've done so far is not based on science. We're not guessing. We're actually using the guidelines based on observations and based on research. But yes, I mean, there are people who need it the more than others. And for example, I'll start off from a story and then I'll go to the data. I mean, over the last year, I've pretty much almost everybody I've taken care of who was very sick with COVID in the hospital were people who are older, specifically older than 75, and they didn't get a shot in the last year, but they might have gotten 6 shots in the first few years of COVID. So that's the people I saw. Number two is the data shows that the antibody response, particularly in older individuals, wanes fastest compared to other people. So it makes sense that you would want to boost their immunity. And we know that in multiple studies that not having a recent vaccine is a risk factor for getting hospitalized and dying, even if you might have gotten vaccines earlier. So I think what is true is that we need to continue to look very critically at the data. And as we get more immune experience, you may not need as many vaccines. And certainly a healthy person who's under the age of 65 would have a very low risk compared to somebody who's older than 65. But that's not to say that they're not certain groups like we talked about, pregnant people, etc. So the question is, what kind of science is science? Is it science that you need to study first? But there are challenges with that because if you do a randomized control trial of a vaccine for the season, that's the reason why we don't do randomized control trials for every flu vaccine every year, because by the time you take to finish it, and you need a lot of people because so many people have been experienced on COVID, the season's already done.
Right.
So in essence, it's kind of saying, giving a rationale for something that it's kind of a self-fulfilling prophecy, or maybe giving you an unattainable goal that's not practical. So, but you know, I do agree that we continue to need to be critical and ensure that you're getting the bang for the buck. But I'm not really sure that we've settled down necessarily in a pattern yet with COVID.
Yeah, and I think you've discussed this, but I think there's still some confusion as to who is eligible to get this vaccine this fall. What are some of the comorbidities that would make us still eligible to get it, and who absolutely will not get it?
Yeah, so I think what I'm worried about is people just see the headline and think they're not eligible. But actually, if you really look at the criterion, and again, we need to see a little bit more details and have more bodies weigh in and give something official. It accounts for about 1/3 of Americans when you think about people with comorbidities of all ages and those who are 65 and older. So anywhere from like 100 to 200 million Americans. That means a lot of people. So if you look at the original guidelines there for what a comorbidity is, it's actually pretty loose. Includes things like BMI or body mass index, diabetes, chronic disease like heart disease, lung disease, vascular disease, even things like mental health in some cases. So it's fairly broad, but I'm worried that people may not think of themselves as being eligible, including people who really should get it for sure, like those who are older. And we know this because whenever you have a targeted guideline in general, it's hard, it's an obstacle even for people who are targeted to even get it, and there's less access. For example, we used to have the flu vaccine as a targeted guideline for very young and very old, and it was changed. And what was found was that people who even in the targeted group didn't get it because they were confused, and people were confused as if they were going to be eligible. But when you made the vaccine universal, the people who really, even the people who were originally targeted, more people got it because it was just an easier message. So that's, another aspect of all of this that I think some people are worried about.
Dr. Chin Hung, thank you so much. Our final speaker today is Dr. Jarir Radvoisian, who will discuss the importance of the PEPFAR program, whether it will be reauthorized this year, and the projected number of deaths and infections that resulted during just a 90-day pause in funding earlier this year. For background, Dr. Radvoisian will also discuss HIV antiretroviral therapy. Welcome, Dr. Radvoisian.
Thanks so much, Sunita. Hi, everybody. Thanks for this opportunity to talk about PEPFAR. Can you hear me okay, Sunita?
Hear you just fine.
Yep. Okay.
Yeah.
PEPFAR is the U.S. President's Emergency Plan for AIDS Relief. That's what it stands for. It's one of the most impactful global health programs ever created. It started in 2003 under President George W. Bush, and it saved 25 million lives and helped control HIV in over 50 countries around the world. It's really proof that American leadership can drive change at a global scale. At its core, PEPFAR provides antiretroviral therapy, as Sunita said, that's referred to as ART, to people living with HIV. Over 21 million people have been put on HIV treatment around the world, thanks to PEPFAR and the support from the American people. ART is simple, it's powerful, it's transformative. It's for the most part a once daily pill. It suppresses the virus, it saves lives, and it stops HIV transmission. So people on treatment not only live longer, they actually don't pass HIV. So treatment in some ways is actually prevention. And that's why we say U equals U. If you're undetectable, you're untransmittable. But here's the catch. Treatment only works if it's uninterrupted. The treatment is a daily regimen, as I mentioned. This year, as Sunita mentioned, when the new administration started, they announced a 90-day pause on all foreign aid, including PEPFAR. And due to this policy decree and other delays in Washington, this has been a direct hit to the global HIV response. Shortly after the administration's announcement, it issued a limited waiver for certain aspects of PEPFAR programming, but certainly more than half of PEPFAR programming is still has been paused and is no longer operational. The waiver process itself was poorly administered. There were operational challenges that persisted across several countries. Their payment systems were delayed, which led to delays in distribution to partners around the world. Guidance was unclear to implementing partners, and there were significant disruptions to service delivery, including people's access to treatment, including several clinic closures in many parts of the world. The waiver also excluded support for HIV treatment programs that is the very HIV prevention programs that are the very backbone of epidemic control. So without treatment, viral suppression is lost, transmission increases, and lives are put at immediate risk. Our team did an assessment of what this 90-day pause on foreign assistance for HIV could look like. We have published the study to show that up to 100,000 preventative deaths would occur in just 1 year due to this 90-day pause, and that was a conservative estimate. Subsequent modeling and studies have confirmed that these disruptions are likely to remove thousands of people from treatment regimens that exist around the world, and tens of thousands of new infections would be caused because people were undetected and untreated. This is not hypothetical. It's actually an unfolding reality now. Moreover, when people living with HIV are forced to interrupt treatment, they are no longer biologically suppressed. This state of suboptimal treatment increases their risk of drug resistance, undermining both individual outcomes and population-level progress, putting anyone at HIV at danger, whether you're in Uganda or back here at home in the United States. Sunita mentioned the PEPFAR reauthorization and its future prospects. This past March, The PEPFAR authorization expired. This was a separate process than the 90-day hold by the administration. It just happened to be around the same timing. While this does not mean that the program has ended, it significantly constrains its ability to operate effectively. The lapse in authorization also weakens congressional oversight, and it grants the current administration broader discretion to modify and restrict the program without legislative checks. So this program has always been bipartisan in the past. It's always been results driven, and today it's stuck in political limbo. If we don't secure a 5-year reauthorization path for PEPFAR, it could lead to more devastation. According to one other estimate, ending PEPFAR could result in up to 11 million additional new HIV infections and 3 million additional deaths by 2030. And that's just a subset of PEPFAR countries that were studied as part of this analysis. So we're urging Congress to act quickly, because delays and policy delays can lead to more lives being disrupted and more lives being lost. And I just want to maybe take a step back and add one more contextual point to this beyond HIV. We're seeing dramatic cuts to global health. I know others have discussed this as well across the board. 80% of global health budgets have been cut as part of the administration's actions, and the proposed budget that Congress is now considering is also considering a foreign aid budget that is roughly about 80% less than what prior years have been funding. So the consequences are going to be devastating, not just for HIV, but across all global health programs, child survival programs, TB programs, maternal mortality programs. In many countries, these programs are very much integrated in serving people. And so a loss of funding in one of these program areas causes disruption in other areas. So I'm happy to answer questions, and thank you again for the opportunity.
Thank you. Earlier this year, I interviewed your fellow Yaley, Dr. Richard Sutton, who said that, with when you cut out funding for HIV/AIDS, and when people no longer get their treatments, the weakened compromised immune system makes them vulnerable to a host of other diseases, such as cancers. Could you talk a little bit about that?
Yeah, no, absolutely. We have to remind people that HIV, at the end of the day, is a condition that attacks the immune system. So having a compromised immune system creates all sorts of vulnerability to other disease areas, and so including COVID. And we saw initially that there was a lot of comorbidity happening in certain areas where HIV was very prevalent. And so when you're on a suboptimal treatment, or meaning you're not taking treatment every single day, or you're taking treatment for a week and then you stop it, you take it again 2 weeks from now, anything other than what currently is CDC approved, which is FDA approved, a daily oral treatment, is considered suboptimal. And when you're on a suboptimal treatment, then you introduce all sorts of risks to not only your HIV's viral suppression status, but to hosts of other issues, as you mentioned.
Yeah. And how certain are you that PEPFAR will be reauthorized this year?
Well, I've lived in Washington too long to make any bets on any outcomes related to what happens here. What I am certain about is that this moment has galvanized a lot of energy and activism in activists in ways that we haven't seen since the 1980s, and when HIV first came onto the scene. And so you see HIV activists disrupting congressional hearings, protesting, marching to the State Department and other areas here in Washington. So there's been a re-energizing of the HIV movement that has put HIV back on the map when many people thought HIV, the threat against HIV was over. And so I'm optimistic that energy will transition to hopefully a more effective policy and soon. But the gridlock in Washington is at an all-time low, and getting anything done in this Congress, including the president's own agenda, is a big hurdle.
Yeah, absolutely. Hari Adivaricar of India Currents has a question for any of the panelists. Hari, could you please ask your question?
Yeah, hi. Thank you so much for doing this. I'll just be quick because I know we don't have much time. Could any of the panelists speak about access to vaccination, epidemic control, healthcare, basically all the things that you've been speaking about for immigrant communities, especially those who have been imprisoned, given recent changes in policies, how does that affect these extremely vulnerable communities, and not just them, but other vulnerable communities like them as well? Thank you.
Good question. Who would like to take that on?
I'll take a quick crack at it, Sunita. A friend of mine says vaccines don't prevent disease. Vaccination prevents disease. You have to move the vaccine out of the refrigerator and into arms. And as Hari has just suggested, a diminution in resources that go out to local public health departments and their partners will make it more difficult to reach a whole variety of populations out there that take extra effort to deliver the vaccine to the people. And imprisoned people are one group already that are under-vaccinated and have not often been considered, despite the fact that they're all together in a congregate facility, and we have the responsibility for their health care. But this is true of many other populations. So this lack of attention and a withdrawal of resources from preventive health services goes right to state and local health departments and begins to limit their capacity to do the job. Incidentally, these are agencies that are chronically underfunded.
Thank you. We will end with your 30-second sound bites of the most important takeaways you'd like reporters to take away from this briefing. Why don't we start with Dr. Schaffner?
So thank you very much. And apropos of COVID vaccine, I would just like to alert the journalists to the fact that the CDC's Advisory Committee on Immunization Practices will meet on June 25th and 26th, where they will vote on what the COVID vaccine recommendations are going forward. Now, we've heard from the Secretary on X, and it's a much more targeted approach than previously on X. People age 65 and older, and those younger who have chronic medical conditions. I draw your attention to 3 issues. I don't know how my colleagues will vote, but they may try to expand those recommendations. The first is to pregnant women. The second is young children, age 6 months to age 2 or 4, undetermined, because they have rates of hospitalization that are comparable to the rates of hospitalization of people age 65 to 70. So there's attention there. And the third population is that the CDC often puts in a recommendation that says, and beyond all those specific recommendations, anyone else who wishes to receive the vaccine may. All of those would be expansions beyond what's on X. So tune in to what the CDC's Advisory Committee is going to say, and then how this difference, if there are differences, are resolved is still uncertain. We are in unusual times.
Yes. Thank you, Dr. Schaffner. Dr. Newman?
Sure. Viruses steal life, take away liberty, and make the pursuit of happiness absolutely impossible. Vaccines make all of these things happen. Being anti-vaccine is fundamentally opposed to the founding principles of this nation. Freedom begins with freedom from disease. And essentially hearing anything else from elected officials, I would say, is probably unconscionable.
So many headlines right there. Thank you, Dr. Newman. Dr. Chin Hong.
I'd say 2 things. The first is that there's probably going to be many things that are not going to change with the COVID vaccine, as picking up to Dr. Schaffner. So I think allaying fears of the people, particularly who need the most, is probably going to be the right thing. And then the second thing, which we didn't get a chance to talk about, is that we're probably expecting a summer increase in cases, probably not as big as previously. There's a new variant, NB.1.8.1. That's in Asia and Europe, particularly in Asia, more hospitalizations, some more emergency department visits. It's kind of the right timing. So all of this is really good preparation for our communities to really be up to date on their protection. And don't forget about early antivirals in case people didn't get vaccinated.
Would you suggest getting a booster shot now?
Well, for people who are eligible, which is those who are than 65 can get twice in a year. If you didn't get one last year, like 75% of Americans, I would say just go ahead and get it just because I'm not sure what will happen. And I know that people who may be traveling, like to Asia, Europe, may want to get that, particularly if they're at risk of getting seriously ill, because it's around now and you wouldn't be at home. It maybe give you some more peace of mind to get protected.
Thank you, Dr. Chin Hung. Finally, Dr. Ratavoisian.
Yeah, thanks so much. The stakes for global health and U.S. foreign assistance abroad has never been higher. The COVID pandemic showed us that global health is local health. And for decades, the U.S. has led the world in global health and humanitarian aid. So the real question isn't whether we can continue this aid, but it's whether we can afford not to.
Thank you so much to all our speakers today. Reporters, next week, our briefing will focus on Trump's tax to remittances. So we hope you'll all join us next Friday. Take care.